Equipment Lesson 21 covers tomography and special imaging techniques. An advanced lesson covering content that appears on the ARRT and describes procedures you will encounter in clinical practice. We cover conventional tomography principles, tube motion patterns, special projections, motion studies, and a range of specialty techniques from magnification radiography to arthrography. 13 minutes. Conventional tomography images a selected plane of anatomy by blurring structures above and below that plane through simultaneous movement of the X-ray tube and image receptor in opposite directions. 4 key terms. Fulcrum, the fixed pivot point around which the tube and receptor rotate during the exposure. The fulcrum is the critical reference point. Focal plane, also called the object plane, the level of anatomy that remains in focus. It corresponds exactly to the height of the fulcrum. Anatomy at the focal plane remains stationary relative to the moving receptor, so it records sharply. Anatomy above or below the focal plane moves across the receptor during the exposure, so it blurs out. Tomographic angle, the arc through which the tube travels during the exposure. And section thickness, the thickness of the in-focus layer, determined entirely by the tomographic angle. The most important relationship in tomography, and the most tested on the ARRT, tomographic angle and section thickness are inversely related. Larger angle equals thinner section. Smaller angle equals thicker section. The bar chart on this slide shows section thickness in millimeters at 7 tomographic angles from 5 degrees through 50 degrees. At 5 degrees, narrow-angle tomography, also called zonography, section thickness is approximately 12 millimeters. At 50 degrees, wide-angle tomography, section thickness drops to approximately 1 millimeter. The inverse relationship is clear and dramatic. Narrow-angle tomography, 5 to 10 degrees, thick section of approximately 1 centimeter. Used when broad anatomical zones rather than precise slices are needed. Wide-angle tomography, 30 to 50 degrees, thin section of 1 to 2 millimeters. Used for fine detail anatomy, like the temporal bone and cochlea. For tube motion patterns, in order from simplest to most complex. Linear, tube moves in a straight line. Simplest mechanism, produces streak artifacts parallel to the direction of tube motion. Structures aligned with the motion path are not effectively blurred. Circular, tube moves in a circle around the fulcrum. Better blur in all directions. Reduces linear streak artifacts. Elliptical, tube moves in an ellipse. Effective blur in multiple directions. Fewer streaks than linear. Hypocycloidal, the most complex movement, a figure-8 or cloverleaf pattern. Best blur of all motion types. Used for the finest section quality in demanding applications like temporal bone and inner ear tomography. 5 special projections with clinical applications. AP axial projections. The central ray is angled along the long axis of the anatomy. Used when standard AP positioning cannot visualize a structure adequately. Examples: AP axial clavicle with 15 to 30 degree cephalic angle. Intentional elongation results. The lordotic position, AP axial chest. The patient leans backward into a lordotic posture where the tube is angled cephalically. The clavicles lift above the lung apices, revealing the apex of the lung free from clavicle overlap. Clinically used for tuberculosis evaluation and Pancoast tumor assessment. Oblique projections. Patient rotated a partial amount between AP and lateral, separating overlapping structures. Standard for oblique ribs, oblique lumbar spine, oblique cervical spine, and the oblique hand. The degree of obliquity is specific to each anatomical region. Decubitus positions. Patient lies on one side with the beam horizontal. Left lateral decubitus. Patient on left side. Demonstrates free air rising to the right side for pneumoperitoneum or demonstrates layering of free pleural fluid. The patient must remain in position for at least 5 minutes before imaging to allow fluid or air to redistribute. And stress views. Controlled force applied to a joint while imaging. Demonstrates ligamentous laxity not visible on routine projections. A physician must be present for stress application. Motion studies, serial radiographs taken during patient movement to assess dynamic function. Flexion and extension of the cervical or lumbar spine. Evaluates instability and cord compression risk. Inspiration and expiration chest series. Evaluates diaphragm excursion, air trapping, or foreign body detection. A foreign body may be visible only on one phase of respiration. Swallowing studies. Sequential fluoroscopic frames documenting pharyngeal and esophageal swallow mechanics. Full spine and long bone studies. Full spine scoliosis series. PA projection with the patient standing using a 14 by 36-inch field, approximately 35 by 90 centimeters. PA is preferred over AP specifically to reduce breast radiation dose. The breast tissue is positioned away from beam entry. Standing full leg alignment. Bilateral lower extremity weight bearing. Both require digital stitching of multiple detector positions. The stitching artifact, MIS registration at the seam, occurs when the patient moves between segments. Magnification radiography. Intentional increase in OHD to produce a magnified image. Magnification factor equals SID divided by SOD. Typical clinical magnification, 1.5 to 2.0 times. Small focal spot is mandatory for magnification radiography. At high OID values, a large focal spot produces unacceptable penumbra, completely negating the clinical benefit of the magnification. Subtraction technique, the classic film-based angiography method. A mask image acquired without contrast is reversed and superimposed on the contrast image. Bone and soft tissue cancel out. Only contrast-filled vessels remain visible. Requires the patient to remain absolutely still between the two acquisitions. Scanography measures true bone length for orthopedic planning. 3 separate exposures made on one image with a calibration ruler alongside the extremity, hip, knee, and ankle. Used for limb length discrepancy assessment and surgical planning. Arthrography. Contrast injected directly into a joint by the radiologist under fluoroscopic guidance. Common joints, shoulder, knee, hip, and wrist. Positive contrast, negative contrast, or double contrast. And myelography. Water, soluble iodinated contrast injected intrathecally into the subarachnoid space. Visualizes the spinal cord and nerve roots. Never use oil-based or barium contrast intrathecally. Catastrophic results. Water-soluble contrast only. It is absorbed and safely excreted. 7 facts the ARRT tests most frequently from this lesson. Tomographic angle increases. Section thickness decreases. This inverse relationship is the most consistently tested tomography fact. Hypocycloidal motion, best blur pattern. Most complex movement. Used for temporal bone and inner ear. Finest section quality. Lordotic chest projection. Visualizes the lung apices free from clavicle overlap. Used for tuberculosis and Pancoast tumor. Left lateral decubitus. Patient on left side, beam horizontal. Free air rises to the right, demonstrates pneumoperitoneum. Free fluid layers to the dependent side. Magnification radiography. Small focal spot is mandatory. Large focal spot causes unacceptable penumbra at increased OID. Myelography. Water-soluble contrast only intrathecally. Never oil-based or barium. And scoliosis series PA projection. Preferred over AP. Reduces breast dose because the breast is on the exit side of the beam, away from the entrance dose. 3 special imaging technique questions. The answer is B. The section becomes thinner. Tomographic angle and section thickness are inversely related. Increasing the angle from 10 to 30 degrees means the tube and receptor travel through a larger arc. Structures above and below the focal plane move across more of the receptor during the exposure. They blur more completely, creating a thinner, more selective focal section. This inverse relationship is the most consistently tested tomography concept on the ARRT. The answer is C. The effusion layers along the dependent right lateral chest wall, confirming it is free-flowing. In lateral decubitus positioning, free fluid layers to the lowest, dependent side under gravity. With the patient on their left side, the right chest is dependent. Free right pleural effusion layers along the right lateral chest wall. This confirms the fluid is free-flowing and not loculated, and allows visualization of the underlying lung parenchyma that the effusion was obscuring on the standard upright projection. The answer is D. Hypoesochelioidal. Most complex motion, finest section quality. The hypoesochelioidal motion pattern is a figure-8 or cloverleaf path. The complex movement ensures out-of-plane structures blur in multiple directions simultaneously, producing the thinnest, most complete section with the least streak artifact. Used for inner ear and cochlear tomography. Linear motion is simplest, but produces the most streak artifact. You covered conventional tomography principles and the inverse angle section relationship, the 4-tube motion patterns from linear to hypoesochelioidal, special projections including lordotic chest and lateral decubitus, motion studies and long bone techniques, and specialty procedures including magnification radiography, subtraction technique, scanography, arthrography, and myelography. This content rounds out the image acquisition category, the largest single category on the ARRT at 26% of the exam.